Today we are going to discuss here about Neet PG MCQs. A 30-year-old man with non-hypertrophic obstructive cardiomyopathy presents to the emergency department with an episode of witness collapse. A passerby provided initial resuscitation when he felt no pulse and the man was making no effort to breathe. Upon hospital admission, he is unwell and pulse is 160 beats per minute, blood pressure 70 by 40 mmHg, and reduced conscious level. The electrocardiogram confirms ventricular tachycardia, sinus rhythm is restored with a DC shock. What would be the most appropriate strategy for the long term? So, which one is the best option here? This patient has hypertrophic obstructive cardiomyopathy and severe tachycardia and BP is low, hypotension severe, and we provide him DC shock. So in this condition, amiodarone is a false answer because it does not decreases the mortality rate, whereas sotalol and verapamil is also not a good option, and dual chamber pacemaker is not helpful. So the best option here is automatic implantable cardioverter defibrillator. So this one is the best answer because this has the ability to correct such irregular rhythms and also decreases the mortality rate. Now, a 48-year-old man with hepatitis B admitted via his GP with history of breathlessness. He has signs of chronic liver disease and does not want to stay in hospital. His international normalized ratio is 2.8. Chest X-ray appears normal. The nurses comment that his oxygen saturation drops from 98% to 91% on room air. Every time he gets up to leave, what is likely diagnosis? So this is not a cause of aspiration pneumonia here because this is not indicate this is like a aspiration pneumonia, and this is also not a cause of pulmonary embolus, and so the best option here is hepatopulmonary syndrome because this patient has hepatitis B, chronic liver disease, and now shortness of breath, and his INR is normal. That's why this is not a case of pulmonary embolus. So this is a case of hepatopulmonary syndrome. Now, 67-year-old man presented to emergency department with epigastric and left upper quadrant pain. For the third time in a year, he had suffered from diarrhea for around 18 months and claimed that his weight had decreased by 12.7 kg. The paramedics who visited the accommodation noticed empty whiskey bottles by the rubbish bin. His serum amylase was within the normal range. What diagnosis fits best with this clinical picture? This patient is alcoholic and epigastric left quadrant pain, and this is suffered from diarrhea last 18 months. So this is pancreatitis, alcoholic pancreatitis, and this is a case of chronic pancreatitis. Now, 35-year-old man complains of paroxysmal steatite episodes consisting of rising epigastric sensory feeling and fear. The episodes last up to a minute and are followed by confusion lasting up to an hour. During the episode, his wife has seen him performing lip smacking, chewing, and swallowing movement. What is most likely diagnosis? Frontal lobe epilepsy, idiopathic generalized epilepsy, occipital lobe epilepsy, parietal lobe epilepsy, or temporal lobe epilepsy. So, which one is the best answer here? This is a case of, if occipital lobe epilepsy means vision difficulty, so here is no visual hallucinations. And here is lip smacking, chewing and swallowing movement difficulty. So this is due to mainly, write the answer in a comment box. Okay, now your hospital has been altered to the possibility of a nearby chemical spill, and number of patients are on their way to hospital. There are reports of chemical having a smell of rotten egg. So this question is very simple and easy, and so many times they ask such MCQs in examination in Neet PG. Rotten egg smell seen in where? In which poisoning? In cyanide poisoning, we see what kind of a smell? Almond smell. In arsenic and in selenium, the smell is garlic. And in case of hydrogen sulfide, the smell is rotten eggs. And naphthalene is mothball. So here all, in cyanide there is almond smell, in selenium and arsenic there is garlic smell, in naphthalene there is smell like mothballs. Okay, now a patient with chorea type movement and cognitive impairment is diagnosed with Huntington's disease. How many repeats of abnormal triplet sequence would typically be found in a patient with Huntington's disease? So this question asked. So this is typical MCQ, but answer is more than 37. Okay. 82-year-old woman presents with sudden loss of vision in her left eye. On further questioning, she complains of left-sided headache over the past few weeks associated with tenderness of her head when she brushes her hair. On examination, her vision is reduced, continuing counting fingers in the left eye. The left relative afferent pupillary defect is present. Fundoscopy reveals a pale swollen left optic disc with some flame-shaped hemorrhage. The right eye is entirely normal and urgent ESR is 72. Which one of the following management options should be carried out first? Firstly, you have to understand what is diagnosis here. Anybody wants to write in a comment box? So diagnosis, this is a case of temporal arteritis. This is vasculitis. So there is vision loss. What is your best step? If you are a doctor, your best step is temporal artery biopsy? No. Temporal artery biopsy is required but not now. Ophthalmic outpatient review? Not now. Administration of high dose systemic steroid, this is the best answer. Firstly, treat the patient, otherwise he is going to lose his vision. So always first step is to high dose of systemic steroids now. 43-year-old woman presents to the emergency department after an overdose involving a mixture of medications including paracetamol, citalopram, sodium valproate, fluoxetine, ferrous sulfate. You are contemplating administering oral activated charcoal. Which of the following factors would be most strongly influence your decision to administer or avoid oral activated charcoal? So this question wants to ask when you are going to avoid oral activated charcoal. When? Guys, the patient is asymptomatic, we can but not comfortable this option. Charcoal should be used only in modified release preparation. Charcoal minimize toxicity given within 1 hour over iron dose. Administration is less effective after mixed overdose. Guys, what? When charcoal is contraindicated when there is absence of bowel sounds. Why? This is a case of paralytic ileus. If you give charcoal, activated charcoal, so that time there is a gastric aspiration, chances are very high. So absence of bowel sounds is an absolute contraindication. 42-year-old woman tells you she has developed fears of getting lost in the crowd. In crowded place, the fear becoming very anxious in open places. Okay, and if in closed place female is having phobia, that means claustrophobia. She also shares that experienced panic attack. Here is open space, not closed. So, and crowded shopping mall has suffered these attacks intermittently since she was a teenager. She is physically healthy and so far has no history of mental illness. What is most likely diagnosis? So here the best, this is not a case of social phobia. Social phobia means to interact, to speak with others. So this is a case of social phobia. This is an agoraphobia. In open space, in crowded place, patient fear, that means agoraphobia. And acrophobia is a phobia of height. Acrophobia is a phobia of height. And bathophobia is fear of death. And dissociative disorder is different, like dissociation of autism, not autism, dissociation of amnesia, personality identity disorder, and multiple personality disorder is dissociative disorder. So hope it's clear. So answer here is agoraphobia. Answer is agoraphobia. Everything is this. Okay, 72-year-old man with ischemic heart disease is on a variety of medications following a myocardial infarction 12 months ago, including aspirin, atenolol, lisinopril, amiodarone, and furosemide. He is becoming progressively breathless, and his cardiologist sent him for pulmonary function test, which shows a restrictive ventilatory defect in decreased gas transfer. Which one of his medication is most likely to be the cause of these abnormalities? So guys, this is a case of pulmonary fibrosis, we can say, and the drug induced, that one is amiodarone. Amiodarone causes pulmonary fibrosis. Okay, so this is the answer. 52-year-old man attends the gastroenterology clinic for review. He complains that his breast appear to have enlarged slightly over the past few years. What is the cause of gynecomastia and cirrhosis? If patient has cirrhosis, okay, so what is the cause behind gynecomastia in case of cirrhosis? Furosemide, is furosemide not causes gynecomastia? Gynecomastia caused by spironolactone. Excess level of corticosteroids? No. Excess energy intake from alcohol? No. Excess level of testosterone? No. But the best answer which causes cause of gynecomastia and cirrhosis is altered estrogen metabolism. So answer here is A. So guys, thank you for watching this video. This is sample paper second. If somebody is new on my channel, please subscribe it, and if you like this video, put like on it, and also watch Neet PG sample paper part 1 also. Thank you for watching. Good day, goodbye.